started. This is Dr. Ogilvie, orthopedic surgeon from the University of Minnesota, who's going to talk a little bit about soft tissue tumors. There.
All right, thanks. And then at the end, we'll do some more presentations about that foundation and the things that we do here. So we'll get started with this. Just to say a little bit about me, I did my medical school at the University of Minnesota and then residency in orthopedic surgery at University of California, San Francisco. And then I did a musculoskeletal tumor fellowship at the University of Toronto, which is a good place to see a lot of stuff because of their large referral base and the way they handle subspecialty care there. And then I worked at University of Pennsylvania for about 6 years and then was recruited back here. And I do a lot of tumor surgery, also take trauma call at the level 2 and level 1 center and do some arthroplasty and try to keep busy. I wish I was all tumors. So it's fun for me to come up here and talk to you a little bit, and please feel free to interrupt me at any time and I will answer questions at the end, or if someone wants to talk to me afterward too. That's all good. So I'm going to talk about soft tissue tumors. Not going to talk about osteosarcomas and bone tumors very much today, but we'll talk about these bumps. And it's important to recognize that they exist. It's hard to diagnose something you've never heard of. Very difficult. And we'll talk about some of the do's and don'ts and the approach to these things, and then become familiar with some of the specific tumors. The focus is on the extremities. As an orthopedic surgeon, that's where I see stuff. But some of these things also can occur at places in the head and neck that I really don't want to go, and other organ systems. But I'll talk mostly about the extremities. The intent is to expand your differential diagnosis, and we'll talk about some rules or guidelines, but there's exceptions to just about everything, unfortunately. And so presentations of things can certainly vary. So we'll define them and talk about how they present and then some of the treatments and the challenges therein. Talk about the benign malignant tumors and some of the imaging and history and presentation of similar conditions such as injuries that often will fool people. So soft tissue tumors, it sounds like a pretty general term. It's actually a little bit more of a loaded term if you haven't run into it. It generally refers to mesenchymal or connective tissue tumors, and nerves, that's not mesenchyme. Well, the epineural tissues are considered that the nerve sheath tumors, for example. You get smooth muscle tumors in the vessels. We'll count the cartilage tumors as well, even the synovial fat and muscle. So those are the general cells of origin. And we have a lot of tumors, I'll say a number of tumors that we really don't know their cell of origin. For example, the unfortunately named Synovial sarcoma doesn't have anything to do with synovial. Sorry. It's just the pathologist thought, some pathologist somewhere thought, this guy looks like synovial. We'll call it Synovial sarcoma. And he was wrong with the name stuff, and it makes it a little confusing. So we will talk about rare things and common things that you ought to be aware of. So sometimes you think, you don't want to, think every little lump and bump is some crazy, weird, rare malignant tumor. Fair enough. The only thing I learned in dermatology in medical school is you have to be familiar with the common things and the rare things that are dangerous. So this is kind of the rare, dangerous lecture. I suppose we'll cover that stuff. So there are out there. You'll see some of them. But I already skipped. Oh yeah. So they're not super common. Only about 12,000 of them this year of the malignant soft tissue tumors. All right. So have a differential diagnosis. There's a lot of people that will approach things, and it's maybe easier to say, well, it doesn't look like this, it doesn't look like that, and they never really get to what it does look like, and then you say, oh, well, these are the possibilities of what it could be, and then what should we do next to sort that out? It's tempting, but have an idea of what it is, take a stab at it, and then work through that. I'm a big proponent of, does everything fit together? Do things make sense? And so you want to say, for this mass or this unusual pain, what's the explanation? If you don't have one, then, and you really have, I have no idea, I can't even come up with a differential diagnosis. then you probably need to do some more diagnostic work, or at least a close follow-up or something. You need to keep working on it, rather than say, oh, it doesn't hurt, I'm sure it's nothing. So get a good history. We'll start there. Pain history. So malignant tumors, unfortunately, they're usually not painful until they're large. Well, unfortunately or fortunately, I guess if they're painful smaller, then we might catch these earlier. And I think there's somewhere in the back of your subconscious mind, you probably all think that, well, if it's evil, if it's malignant, it ought to be painful, right? You know, it's bad, it ought to hurt. Well, that doesn't happen to be the case with these. In fact, the painful tumors are more benign painful tumors. So if it's something, small painful tumor, it's more likely to be benign, actually. So you don't want to ignore pain if it's, especially if there's not a good explanation for it, if it doesn't fit the history. No significant trauma. It's lasting longer than you expect an injury to last. Maybe a little night pain. So if things don't fit together, the location's not quite right, then you got to pursue that more and try to pin the patients down on the history. Now some patients are lousy historians, so then you got to do a little bit more. So pursue that unusual pain. I think also people think in the back of their mind, well, what am I going to learn if they say, well, it hurts right there and just pressing right on it? I'm not a sadist, you know, I'm not there to torture the patient. Well, you learn whether it's pain or whether that pain is actually tenderness. Is it referred pain from the back? Is it really not tender at all? That gives you information. So yeah, if they say, well, it hurts right here, doc, you really kind of want to feel around and see, is it localized or is this really diffuse? That will help you with your differential diagnosis and help you treat the patient. So you do a hands-on exam. If you find a mass, then we'll get an MRI, and that's our standard for soft tissue masses. You think about an X-ray, especially if you think that bone is part of the pain generator, and if you have persistent pain with little or no or subtle X-ray changes, then MRI gives you a ton of information. They're all very sensitive to costs, and we don't want to over-order things. But it tells you the anatomy, it shows you inflammation, it shows you if there's any masses, and it can be a real shortcut to sorting things out. Or maybe telling the patient, you know what, you have nothing anatomically going on in there, I'm sorry it hurts, it's probably a soft tissue injury, or let's give it some more time, but there's nothing to worry about. And at the very least, your follow-up appointments to re-examine someone if it seems benign and explainable. It's nice to see someone a couple times to make sure you're not missing anything. So masses, talk about pain a little bit. So what do you expect out of a cancerous tumor? It's going to grow. It's not earth-shattering news. So benign tumors, you may or may not have a growth history. Some of them get to a certain size and kind of stop. If something decreases in size, it's more likely to be a non-tumorous process, like an injury. It had some swelling, hematoma has come down. You will get hemangiomas, these big dilated clusters of blood, of veins essentially. They can fluctuate in size depending, if not all of them do this, in fact only a minority of them do this. So if they're in a dependent position, like the veins on the back of your hand, they might swell up a little bit, or if a person's very active, if they're connected to a muscle where the blood flow is increased, you might see that they'll fluctuate in size. But that's generally not a malignant feature, so that's reassuring when something does that. So when you have a malignancy, what does it usually behave like? It usually becomes noticeable over several months. And someone might say, I noticed it 6 months ago, or I always say, well, was it there at Christmas time? Like, well, yeah, I guess it was. How about Thanksgiving? I think so. How about summertime? No, it wasn't there during the summer. I try to track these events and help them put it together. And then we have our exceptions. So the epithelial sarcoma and the dreaded synovial sarcoma, which will come up again. They just didn't cooperate with this guideline very well. I've seen some of these that have a synovial sarcoma. One of my patients they had for 17 years and really didn't do much, and then it started growing over 3 or 4 months, and it's a high-grade malignancy. How can they do that? How can they do that and they don't spread and kill the guy 10 years ago? I don't know, but it's important to know that some of these malignancies, just because they've been there for a long time, it doesn't mean they're nothing. So unfortunately, this is one of the exceptions. And then I comment on the name being inappropriate. All right, and a good history will also get you the injury details. You really pin the patient down, they come in this big mass, and they say, well, you fell, and did you have that the day before you fell? Nope, so it came up right after you fell, yeah? You get all black and blue, yeah, I sure did. And is it getting smaller? Oh yeah, it's a lot smaller than it was last week. You're like, okay, this is all fitting together very nicely. You know, and so if you can ask the right questions, that's really helpful. And then if someone's on Coumadin, or you know, they take aspirin for their heart, or on Plavix, or all of the above, you know, that makes them more susceptible. Now, is everyone, you know, I don't even have to show your hands, but if you spend enough time in a hospital, especially in the operating room, you're going to run into equipment and stuff. You know, you bump into things. Never walk backwards in a hospital. You're going to hurt yourself. So they have all this equipment and things piled in the rooms and in the hallways, and you run into things all the time. So I get home at night and I think, where did I get that bruise? I don't even remember. So just because someone doesn't remember bumping into something and getting a little hematoma, that doesn't mean that they are senile and they've lost their mind. So that may happen to you as well. So not everyone's a perfect historian. And if they're on a blood thinner, you think like, well, you have to remember when you would have hit yourself. So what are you going to run in? What parts of your body are you going to bump into stuff? Is it going to be your axilla? No, not unless you're wearing crutches or doing some extreme sport. You're going to see people with hematomas and bruises on the side of their legs and their knees, side of the hips. Really classic spot. Some of these perforating arteries that serve the skin come up through this very thick muscular fascia too, and you bump into something and you can get shear injuries of these vessels right at the top of the fascia. So some of these people get pretty impressive hematomas on the side of their thighs when they do this. So, so you say, that's a classic location. They're on blood thinners. They don't remember the trauma, but yeah, okay, I can let that one slide. I'm going to keep a close eye on this. I'm going to maybe repeat the MRI, see it's getting smaller, or at least watching closely. They did get black and blue. So you want to nail down that history of the business, so you don't miss anything. So be vigilant. We talked about the hands-on exam, pursuing those soft tissue masses. Note the size, depth, and consistency. And I finally found a reference for this today. I was looking for it. It's like in all my lectures, and it's not. I don't. It's from a Swedish study of about 17 years, and they noticed that this was on soft tissue sarcomas and lipomas sent into their big treatment center. The things that were greater than 5 centimeters in deep much more likely to be malignant, and they're a little biased because they just see the big bad stuff. But if it's bigger and it's deep, it's more worrisome, and it's up to half of those tumors are malignant in those that are sent into the referral centers. So how do you know if it's something is deep? Well, if you flex the muscle underlying or right where the mass is, and then the mass all of a sudden is no longer movable and more firm, then you think, okay, it's in the muscle. If you flex the muscle and the mass is still, you can still move it around over the top of the muscle, you think, okay, well, that's in the subcutaneous tissue, a little less worrisome. And then you can, is it kind of soft and squishy like fat, and lipomas that have a pretty characteristic features, especially if they're not growing rapidly. And then the hemangioma sometimes too, you can kind of look at it and say, oh, it's a touch blue, you know, like a vein, and it's really, like it's just completely compressive, and then it seems to fill up again. I don't know, that's something venous. You gotta watch out for arteriovenous malformations, where you have artery connected to a vein, especially ones in the trunk that can get pretty darn big. Sometimes you can feel, with the stethoscope, you can hear a pulse in this very large superficial vein, or you can feel a thrill. Those you don't want a needle biopsy in clinic. It'll be quite a mess because you're holding pressure for a very long time. When you have arterial flow in a vein, the vein is really thin-walled and it tends to dilate the vein out. And you just don't want a thin-walled garden hose with arterial flow in it, a hole in it in your clinic. So I would you gotta do your hands-on exam before you want to biopsy those babies. I stay away from those. Those are interventional radiology problems. So pursue that bump that doesn't resolve quickly, whether it's come gradually or just been noticed and may even be painless. So MRI is really our gold standard for looking at that, and consider X-ray if you suspect bone involvement. So what do we do when we do, we often do needle biopsies in clinic, or maybe open biopsy in the operating room if that's not practical for some reason. Find out what it is. How do we treat these? The main treatment is surgical, getting these all out. We need to do a negative margin surgery. So that means when you hand the pathologist, I just took out a 12-pound tumor yesterday, when you hand the pathologist the tumor, it's like volleyball size, it's pretty cool. When you hand the pathologist the tumor, they put ink along the whole outside of it, and then when they section it and cut it, I don't know how they're going to deal with this big thing, when they section it and cut it, they look and see where the ink is. And if there's ink right on the tumor cells, they say, you have a positive margin. And you say, well, what's on the other side of that tumor cells? Is it more tumor cell? And whatever it is still back in the patient. And we never assume that your surgical plane was right between the last tumor cell and the first normal cell. I'm sure you're fine, right? Well, that's a little worrisome. So that's a positive margin, and sometimes we have to, the radiation can help with that. In some circumstances, we want to go back in and take out more tissue, which is why we discourage people from popping these out in clinic. About half the time when that happens and we go back in and take more tissue, we will have, there'll still be a little residual microscopic tumor. Anyway, why negative margin resection is our standard of care? We use radiation also pretty universally on anything that's high grade and anything that's large. It's really small, superficial tumors. It's a little more controversial whether it's needed. It affects the local recurrence rate, and whether you do it before or after, there's similar survival rates and some issues with wound complications, which I'm not worried with. If you do pre-op radiation, you can give a lower dose in a smaller field, which seems great, but we get more wound problems. So you have to balance all those things in as you're choosing which one to do. Chemotherapy is not a silver bullet. It doesn't work all that great. It's more helpful in some soft tissue sarcomas than others. We certainly do it for the larger, higher grade tumors, and it's more and more widely practiced. And the Synovial sarcoma, we have a good regimen for that works pretty well. Rhabdomyosarcoma is probably the most sensitive, and everyone with that will get chemo. But in other tumors, it's not as helpful as you think it ought to be. So it's really all about getting the thing out of there. All right, and then after it's out, what do we do to follow up? I watch patients for at least 5 years, and then I might turn them over to a long-term follow-up clinic if they have chemo or radiation, because you have some long-term issues with those things, such as secondary tumors, or depending on the cardiotoxic chemo, you worry about people having heart problems later on. But following pretty closely the first 2 years. Local recurrence of metastatic disease, the great majority happens during the first couple of years. So we watch them every 3 or 4 months. And watching usually means a CT of the chest and MRI at the site, unless it's something like your finger where it's really easy to examine and know if you've had a bump regrowing. The CT scan of the chest reflects where these are most likely to metastasize to. Soft tissue sarcomas are not super interested in the lymph nodes. Angiosarcomas maybe a little bit, synovial sarcomas a little bit. That's less than 10%. Nothing like the carcinomas or lymphomas or anything like that, melanomas. They really get filtered all out by the lung, and so that's where you're going to see the metastatic diseases in the lung far and away more than anywhere else. And so that's our general screening. PET scans we're using in concert with the chemotherapy. We give somebody a PET before chemo and then after their first dose of chemo. And we're hoping that it'll be a magical tool for telling us whether that response to chemotherapy is going to correlate with survival. And so therefore you're on the right chemo regimen and we're going to give as much as we can. Or if it doesn't do anything with chemo, maybe we should just go take it out right away because we're wasting our time. It hasn't been that straightforward, but that's something we're studying and trying to demonstrate. And you'd like to find that, and there's a ton of different kinds of soft tissue sarcomas, so it's hard to get your numbers up in a rare disease. There's dozens of types. But we'd love to know that for synovial sarcoma, when you give adriamycin, your response to PET, it correlates with prognosis. And so, this cardiotoxic thing, if we give it and you don't respond, you don't have to get the rest of it because it's not going to be good. But we'd love to have that all sorted out, and that's an area of active investigation to look at that type of thing. PET scan, I don't know how familiar you are with PET. It's combined with CT scan right now. We really don't do them alone, and that allows us to see things down to a centimeter. It's simply glucose use. You can use different, there's a radioactive tag on the glucose. You can use different molecules to see different things. But basically, it's just glucose use, and you think, that is not very specific, and the answer is, yeah, that's really not. So it's just a really gross measure of metabolic activity. So, well, if I'm healing my broken bone, isn't there going to be some metabolic activity there? Yes, there is. And so you have to sort that out. If the patient has an injury, they have a little arthritis, they have some gout, if there's something else going on that might show some PET activity. So that's what we're using right now to try to help us understand treatment response. And also, it looks at all the soft tissues in the whole body. If there is some rogue lymph node somewhere, hope we can see it. All right, so the challenges that we just talked about: lung metastases, doing the big surgeries, you may alter function if you're removing a muscle or a nerve, or even the vessel. My volleyball tumor lost its superficial femoral artery, so I at least had vascular there, and we put a vein graft in there now across some fingers, but we got the profunda. So the chemotherapy has limited efficacy, and there's many types of sarcomas. So it's taken a very long time to even demonstrate that it does anything to anybody. And initially, our initial great chemotherapy breakthrough was, well, it doesn't help survival, but it seems to delay events 2 years. You think, well, metastatic disease and recurrence, yeah, stuff like that. So you think is that a breakthrough? Should I care about that? Is it worth it? You know, what's the side effects of the chemo? So it's been a struggle to start getting more specific regimens for specific diseases that show actually improvement in survival. And this is part of the importance of this whole topic, is that this is a tumor where the adjuvant treatments are not spectacular. So if we have a delay in diagnosis and they get metastatic disease, this is very hard to do anything with that. The standard of care still is, if you're going to be cured from this, even with metastatic disease, you want to remove all the gross tumor, because we feel like it's going to activate at some point again, regardless of what we do. That means if you got 3 lung mets, they got to come out unless they completely disappear and they stay away on your chemo and the lottery. But you're going to have some thoracic surgery there to get those babies out at some point if you really want to take a shot at being a long-term survivor. So we'd love to get to people before that happens. And one thing I didn't mention is that for high-grade tumors, the rate of metastasis is in that 60 to 70% range for these. So it's very, very common. Okay, and the radiation complications is high-dose radiation. I don't want that too much, but it's 5 or 6 weeks, 50 to 60 gray, depending if we do it pre or post. Lots of chronic edema, chronic scarring and fibrosis, and if it's up in the groin, around your knee, that can have a functional impact for you, and it's a lifelong issue that doesn't just go away in time. So, this guy walks into your office with mass. Do a good exam and a good history. Do an MRI if you're worried about a malignant or large or deep, even a deep benign tumor, because those often need to come out, so have a pretty low threshold for getting an MRI. Don't operate on it, don't pop it out unless you know how to biopsy something without making a malignancy worse. You're like, I think this is a lipoma, it's nice and superficial, and it's, it's less than 3 centimeters, and it's not at some place where it's like over the thigh. If you make a mistake on the thigh, just take out some skin and we'll skin graft it, and it's not going to have much consequence. If you do it on the finger, it's like, well, that's really tough to cover, or that. We'll show you the top of the foot example in a minute. If you have a diagnosis, don't do anything invasive unless you have a diagnosis and know how to treat it, or can control your field there. So, good thing to do is send it to a tumor specialist. Doing a needle biopsy and getting good tissue is great. If you want to do an open biopsy of a superficial mass, don't go deep to the fascia. You don't want to contaminate that area. I've had a couple patients where people were going to take out a lipoma and they opened it up and it wasn't a lipoma. They could tell that, and they just closed it back up again and didn't do anything. You think, well, that's horrible. Well, that I can correct. I can fix that. I can do an MRI, we can see where the tumor is, and I know exactly where I have to go, and I can do a needle biopsy, and I can go biopsy it. It's much more difficult if they take the tumor out, they didn't have an MRI, and I don't know exactly where it was, and so then I have to, it makes me nervous, and it makes me want to do a bigger surgery. I'm taking a little more muscle in that nerve, and I'm going a little deeper. Who knows where this was? Who knows where or they were, and well, bleeding was after the surgery and was caused by the surgery. So if you get in that circumstance, I would recommend just getting out a little knife and taking a little wedge out of the surface of the tumor and says, all right, it doesn't look like a lipoma. I'm going to take a little bit of it right here, and we're going to call it good, and that's fine. That's a biopsy. We do those all the time. So that's fine. Try to stay superficial. The plastic and general surgeons are very sensitive to cosmesis, and I respect that. So they like to make incisions along longer lines where the pull of the skin and the traction of the skin is going to minimize the scar width. Fine, that's great. Problem is in the extremities, where most people are really pinned down, don't care too much about scars, but in the extremities, those lines are often transverse lines. And the challenge of that is that, that is crossing multiple muscle bellies, multiple structures. I prefer the longitudinal lines, which are going to stay over one structure. So if something is going to get contaminated by the tumor, we minimize the number of things that do when we stay away from the vessels and nerves when we do that. That's what we don't like, the transverse incision. All right, but I don't recommend doing neural biopsies unless you've had some specific training. And if you want to do residency here, we'd be happy to train you. So that's the good. The bad would be to ignore a large unexplained mass, to do a transverse incision and shell out something that's like, well, it didn't seem like a lipoma, and I didn't really have an MRI because I thought it was, it didn't seem like it, and then it turns out to be malignant. So I would just biopsy those if that's what it's looking like. Now, it's not rocket science. These have nice little pseudocapsules. They will pop. They say, but it popped right out, and I just cut it all out in one piece. And when they inked it, it was a positive margin. When I went back in to do the wound bed resection, there was a 2-millimeter nodule of tumor. This is how those things go. So it's not, you think, well, this has got to come out anyway, and I got it all. Right, but that's not helpful. And it seems like it's such a satisfying right thing to do, so it's a little counterintuitive, and that's why I'm crusading here telling you today that that's not the best way to go. For the reason we talked about it, the whole field is assumed contaminated when you have a positive margin. It's hard to tell how extensive the original mass was if you don't have an MR. And I talked about the wound bed resections often have tumor. So the ugly is a piecemeal, partial excision of a deep mass without a prior tissue diagnosis. And then also, when that happens, it bleeds a lot. And so people want to put a drain in. And if you get in that situation where, gee, this is a biopsy, this is bleeding like crazy, I need to put a drain in it, you want to put it, if this is the incision, you want to put it in line with the incision and close to the end. And I usually put it close to the distal end. And so I've had people make incisions and then put the drain way over here perpendicular to it and far away, and then that's contaminates that whole area too. So it can be a little messy if that happens to you. And that's the functional compromise from removing all the contaminated tissues. So we want to avoid that. All right, so some examples. So this was an 18-year-old that had a mass on the top of her foot, and I thought, oh, this is probably a ganglion. This is I've had 3 patients I can think of that had podiatrists come into these things. And they aspirated thinking it was a ganglion, but didn't get anything out. Tried to transilluminate it with the flashlight, right? You're supposed to do that. Didn't really transilluminate it. So I said, well, it doesn't seem like a cyst, but it's bothering her, and we gotta get this out. And so that's what they did. They popped it out, a couple pieces, and it was a synovial sarcoma, which is the most common soft tissue sarcoma in the foot. And they got right down on the bone. The skin is really thin. We really didn't have any pictures of this beforehand, any imaging beforehand. So now I have to create this big hole in the top of the foot, and there's no really robust rotational flap to cover that. So this person gets a free flap, and that's muscle and skin plugged in there. That's a lot of scars for this person who's a little sensitive to that, this young woman. So that would have been better with just an incisional biopsy, and then maybe I could have done a primary closure down on the foot and avoided all that. Actually, her first free flap failed, and she didn't have a second. So that's a tough thing all downstream of this, having a big wound to cover up, and she had radiation as well. All right. Another challenging location is subcutaneous border of the tibia because you have no muscle to protect you. And this is a small, it's a tiny bit, this is a meter and a half, and the plastic surgeon actually popped this out, and the sarcoma, and he then did a CT of the leg, which is not really our gold standard for looking for residual disease. And then he did a nice wound bed excision with a skin graft, very technically well done. He did not check the chest, and he did not send the person off for radiation. So at 4 months, he also discharged the patient. And it's really not exhibiting very good understanding of the biology here that he's dealing with. So this patient had a recurrence at the edge of the grafted area at 6 months. A little nodule came up there. And probably, radiation may have helped with that. Because he did, second surgery was great. And that was all fine. It's technically well done. Again, this is not a big technical issue in these small superficial tumors. It's more of a thought and decision making thing. So this guy, I got to do a rotational muscle flap and skin graft, and we staged him all up and got him taken care of. But that's more than you probably needed. So we'll talk about some specific tumors here. Rhabdomyosarcoma is more common in kids. It's the most common soft tissue sarcoma in kids. There's a big one, gluteus maximus, a teenage girl, 17-year-old. After chemo, it just almost gone. Couldn't even feel it. So fantastic response. You look at that to that, and we were really, really happy with that. I would love to have some test that tells me, that's completely dead. You don't have to go do surgery, but we're not quite to that point where we feel like, oh, it must have killed it all. There's no chance of it recurring, so you still have to kind of go take out that scar area, which is a little tough when there's nothing to feel really. So that is a challenge sometimes. As I said, extremities is my area that I treat, but this is actually more common in head and neck and urinary tract and minority urinary extremities. And these are the ones that can get into lymph nodes too, more chemosensitive. So this one's a little different than some of the others. More common one in adults, and I edited this last year and I forgot to change the name of this. The names of these things are changing all the time. This is now called the undifferentiated Villonodular sarcoma. UPS is no longer called the MFH. It just lacks any true tissue differentiation. It doesn't look like any other normal tissue. And these are high-grade tumors. There's one in the flexure digitorum brevis in the forum, I think is what it was. This guy was a cook in a Jamaican restaurant. So he was a really nice guy, really bad at following up. But I did see him in the gym a couple times, and I know he was doing well. Yeah, this guy comes up to you and shows you this big scar on your arm where you're like, oh yeah, I think you finally recognize it. Anyway, that was and the thick Jamaican accent. I'm like, this guy's asking for trouble or what's going on? Anyway, so he was a good guy. So you can see a little of the MRI appearance, kind of muscle-like on the T1, very bright, and heterogeneous on the T2. There's areas of necrosis where you get big cysts and fluid collections in these high-grade tumors. So that's a pretty common diagnosis. All right, the dreaded synovial sarcoma, we don't know where it comes from. It can grow slowly. It does have a nice genetic translocation, so once we get it, we can really nail down what it is. This can calcify or ossify and have cysts in it, which is really nasty because there's a lot of normal things that do that, like myositis from an injury, like ganglion cysts. So it can imitate a lot of these kind of non-tumor things and then, put that with something that can stick around and unchanged for a long time. And it's just always something that kind of is in the back of my mind that bugs me. I don't know when I see these. See, it's supposed to be bright on T2, but it's really dark because it's so calcified. And here's one that's up here, looks like a Pancoast tumor. And I'm sorry. And then on CT scan, you see this big calcified mass, and there's peripheral calcification. That's myositis that does that. But then you have this more central stuff in the other half of it. I guess I got to biopsy that. And this was a synovial sarcoma in the paraspinous muscles. So those are real tricky ones that can imitate a lot of non-tumor diagnoses, and you've got to have your differential. Watch out for it. I'll draw you some contrast for it. So you see this one is more mass-like. You say, well, what does myositis look like? Well, myositis is often not mass-like. You get these little calcifications within the fibers of the muscle, and sometimes you can feel it, or it'll feel a little hard or firm, but many times it's not very mass-like. say, well, how do I sort that out? Well, you really want to do an MRI to help you there. And you want to do an MRI with contrast, and you're looking for an enhancing soft tissue mass. This should be kind of normal muscle with a bunch of flecks of calcium in it. It's just going to look very dark on the MRI. You're not going to have a real enhancing soft tissue mass separate. And history is important too. If someone says, well, I've got dermatomyositis. This is the myositis portion of it, isn't it? Yeah, okay. All right, that fits with the diagnosis. I have all these skin problems and I got this lump in my leg. The x-ray shows that. I'm like, well, we can do an MRI, but I'm pretty sure I know what's going on there. If they don't have that diagnosis, maybe they're going to make it with this. That's maybe the, I don't know, I think FHL maybe. Also belly ends about there, or something like that. But that just defines one of the muscle bellies. And here's another one, maybe not true myositis. This lady has this ossicle in her IT band. So that's not really myositis, it's not muscle, but heterotopic ossification. And this is what we just talked about, Is that someplace you expect someone maybe to have a post-traumatic change in soft tissue? Because that's someplace people bump into. Yeah, it's right on the side of their legs. I'm sure she smacked that on the corner or something. It's just right there. It's prime spot for a injury and a location. You say, okay, that fits, it makes sense. You don't have you don't have any soft tissue mass, let alone an enhancing one. That just defines the calcification on the x-ray. All right, she doesn't seem to remember getting injured, but that's pretty cool. If I'm worried about it, you can biopsy it. That one, it's like, what's there even to biopsy? You might want to recheck an MRI or exam or something. Okay, here's another, this is a 2-for-1. This is a benign cartilage tumor called an inchondroma with little arcs and little calcification. And this is calcific tendinitis. And so that's very common, supraspinatus muscle, it's going to be painful. That's a pretty common thing. Now, here's a supraspinatus synovial sarcoma, all right? It's in the muscle belly, and you think, okay, well, sometimes when people get labral tears, and they get these big ganglion cysts, that's like a prize winner, but let's do a contrast study, and you say, oh, okay, it's mostly cystic, maybe a little septation here, but really, not much. All right, you need to go through that whole MRI and find the enhancing portion, because this is cystic synovial sarcoma in the supraspinatus muscle, masquerading as a labral cyst in the shoulder. That's a little tricky to get out. We'll talk about that some other time. Here's something that looks even worse. Contrast study, you say, well, that's thicker. The vein is a lot thicker and more vascularized. I'm even more worried about that. Well, this is a guy who pushing something, he felt a pop in his arm and swelled up, got black and blue, went to see his doctor, they're all worried, they got the study, they said, when he comes to see me 3 weeks later, the mass is gone. The black and blue is even gone. When I talked to him about all that, he said, yeah, I got all black and blue right away. He said, did you have this mass before? I know, 5 minutes beforehand, I did not have it. He ruptured his biceps tendon and bled into his arm around the biceps muscle, and then that all went away. And you think, okay, well, if I want to feel better, maybe I repeat the MRI and see that he didn't injure a tumor and bleed into the tumor, so I'm worried about that. But okay, this is all fitting into an injury, and oh yeah, you guys on Ashland too. Okay, I'm starting to feel better. So you want to nail that down. Here's a guy who had a hamstring injury. We'll see this fullness down by the ischial tuberosity, a lot of fluid on the MR, and then later, fullness seems to be gone, the fluid's minimized, so that's just on his repeat MRI. Okay, the fluid went away, hamstring avulsion. Okay, makes sense. I feel better now. Here's another example, the hematoma. See, right on the side of the hip. This is actually a pretty giant person. This is the femur just above the knee. Big person, but side of the thigh, you see the theme here. And these have a characteristic appearance. They get this thick fibrin rim. The hematomas are pretty, they can be distinctive, but you want to make sure that everything fits nicely if you're going to hang your hat on that. All right, and let's see. All right, let's talk about the liposarcoma, another pretty common one. Often they can be associated with lipoma. This might be my favorite slide. So this is the fat in the bone marrow, the subcutaneous fat, and then this is the fatty tumor, and then it's associated with this other non-fat stuff. So this is the good, and this is the evil, the yin and the yang. All right, this is a dedifferentiated tumor. Part of it has gone bad, and you have the T2-rated sequence. All right, it's bright, that's how sarcomas are supposed to be. So that's a liposarcoma. It's got part of the tumor looks like benign fat, and the other part's gone south on you. And just for contrast, I will briefly talk about some benign tumors. So lipomas, there are zillions of them out there. There's genetic predisposition for them. People see them in families. People have multiple ones. Some of those people, they can have them, they can become cancerous. It's not very common. That can happen. Here's a deep one down in the, down in the deep leg. You say, well, what about this spot within it? That's bad, right? Well, you got to scroll through that on the MRI, and maybe an entrapped muscle fiber. Or the radiologist say, I see these septations. It could be. Those don't bother me. But we want a big dark spot in the bright lipoma. That makes me a little nervous. That needs to be biopsied. There's a fat saturation sequence where this all saturates out. Okay, so good. That's behaving like benign normal fat. All right, here's a hemangioma. They tend to be these serpiginous clusters of veins, and I will pretend that that's a feeder vein, and they often have a little fat admixed with them or around them. Very common. This is just in the back of the knee here. That's a little tiny one, but it's just a nice example of a feeder vessel, and we'll excise those if they're asymptomatic. You can inject. They have I forget what the agent is. There's something better than alcohol that they use now. So ideally, you have a tourniquet, you inject there, say, okay, you inject some dye, say it'll take 1.5 cc's. I inject the alcohol in. I don't know how long they leave it in. They leave it in for a few minutes, and then they try to withdraw it out. You're creating endothelial damage, and you're changing the flow within the veins, and so hopefully it won't hurt anymore, and that probably helps about half of the people who get that done. The real big ones, you may have to inject at multiple sites or multiple times to get that result. Not all of them are painful. We also take them out. They are thought to have a high recurrence rate after excision, although I have not experienced that in my practice. It's a relatively low for the patients that are treated. I don't know. You can get dystrophic calcification of phleboliths and these large, long-standing ones. This guy came in with a fixed elbow contracture. He wanted to move his hand and his elbow more, but this is like all through his forearm. It's all through all the muscles there. So you can't. It's like, well, if I take this out, I can't really take it out because then you wouldn't have anything left of your arm. He also had a fixed extension contracture of his hand, and so I thought, all right, well, if I release that. Try to make a fist with your hand like this. You can't even close it. So the fact that his wrist was extended allowed him to make a fist. He had excellent grip strength, and he could use his hand. He just couldn't, couldn't straighten out the elbow, which is super annoying. But any surgery would make him less functional. So not for this guy. That's a pretty extreme. Myxomas are a real watery soft tissue tumor that you get in the muscles. And they're right on T2, and not much in the way of cells, just this myxoid, kind of gelatinous matrix, and some muscle fibers admixed with them. So they do look like soft tissue sarcomas, so we got to biopsy all those. And then I think this is the last one. This is a benign tumor of the tendon sheaths and joints. You see them in the foot, because there's a lot of synovium in the foot. These are actually the true synovial tumors, Pigmented, Villonodular, Synovitis. The knee is the most common spot. It's the biggest joint in the body. Makes sense. We'll see them in the hips. We'll see them in the tendon sheaths of the fingers. They're called giant cell tumor of tendon sheath, but essentially the same process. The way this works is there's a small amount of tumor cells, and most of these tumors they'll make colony stimulating factor, and they'll attract a large amount of inflammatory cells. So our experience in the knee is you can go in and take most of it out and sometimes cure the disease because you happen to get the tumor cells. But then the recurrence rate is really high too because it can spread all over and hide in all the nooks and crannies of the knee, under the collateral ligaments, and between the cruciates, steroid pain. Hard to see everything with the scope. You don't have magnification when you have the knee filleted open and open up the knee from the front end and back. It's kind of a surgery for someone that has a lot of scarring, super painful. So this can be a really annoying disease, but it tends to hit young people as well. And there probably is not a malignant form, but the reason I think this was felt to have a malignant form for such a long time is because the way the tumor looks under the naked eye and under the microscope is dominated by all these macrophages and all these inflammatory cells that are attracted to it. It's just this particular mix of inflammatory cells. And so you can think of like, well, yeah, maybe a malignant tumor might make that and have it look very much the same because it happens to be making that same molecule. And that happened to me once with the lady with a tumor in the leg. You know, we took it out. We said, it's PVNS. It's a really weird space. Okay, and it recurred, and they said, it's a high-grade malignancy. Well, what gives? And they went back and looked at the original stuff. Oh yeah, we got the first one wrong. Sorry about that. So that occasionally happens too. So that's you just have to take a deep breath. All right. Let's see what we can do to save this leg now. Thank you. So it's a tricky disease. Slow growing. It's a form of synovitis. What does synovitis do to the joint? You make it swollen. You can get effusions with PVNS. Sometimes effusions are orange or blood stained. So you get a history of people tapping it. What did it look like? Was it clear yellow? No, it was, it was kind of red-orange. Like, okay, you might have diffuse PVNS. And it can be a single nodule, or it can be this kind of diffuse disease spread throughout the knee. Interesting disease. So any, this is my synovitis soapbox. So any synovitis left to its own devices can cause bone changes. It can cause periarticular erosions, and you'll see that more when you think about various types of the autoimmune inflammatory conditions like rheumatoid arthritis or psoriatic arthritis or those things. So right just off the articular cartilage with the increased blood flow in the synovium and all this inflammatory changes can cause erosions in the bone. So you'll see these little erosions. And PVNS can do that too, given enough time. Gout can do that. Traumatic arthritis, hemophilia, anything that can cause synovitis can cause these periarticular erosions. And so that's helpful when you see things on both sides of the joint. All right, here's someone with first web space wasting, and they had this big nodule right under their nerve, and this is the motor branch had a little neuroma on it, so hopefully taking that nodule off would help her. But she's got an erosion in the hammy that's happened over time. That's not great for. There's somebody with a little erosion in the head there of the first metatarsal. And there's no joint space in the foot, right? So if you get something that's in the joint, well, it'll pop out on the surface of the foot right away. So here's something out on the surface. T1, unlike this, the malignancy is very dark on T2 because of a lot of hemocytic deposition. So these have a fairly distinct appearance. Okay, here's the hand lady again, erosion into the bone. That kind of gives a tip off of what you're dealing with. And here's one, dark on T2. Here's one you say, well, that's not in the joint. Well, the synovium actually inserts right there. So this is synovial base. The mass popped out on the extra-articular side of the joint, which makes you a little worried. It might be something else. But it was dark on T2, so we're pretty confident that what we had. So here's the periarticular erosion. So you get these erosions right next to the joint, kind of coming in, and that's on both sides of the joint. You think, okay, this is an intra-articular process. This is behaving like synovitis. This could be some big gouty tophus or PVNS or something else. Be weird for infection to look quite like that. It's usually more foreign. We've talked about some of the different of this a little bit. This is just one in the carpal tunnel causing carpal tunnel syndrome. That's what one of your hands-on exam. Nerve tumors may or may not be painful depending on sensory or motor nerve. They often are. They're usually this nice little round, satisfying egg-shaped things. Benign nerve tumors, like this on the sural nerve here, you can usually peel the nerve right off and take care of that. Very straightforward. I'll skip to the conclusions. So, consider it a soft tissue tumor for any mass or even an unusual pain that might be a tumor. And pain without significant trauma, persistent pain, night pain. Arthritis, you get a lot of night pain sometimes, but yeah, if that's in your differential diagnosis, that's your diagnosis, fantastic. Consider getting an x-ray. If they got a swelling in mass, consider adding an MRI. If it's persistent pain or pain with the no or subtle x-ray changes, get that MR. A bump that's not resolving in the way you think, whether it's come up gradually or just been noticed, whether it's painful or not, MRI is going to give you a ton of information to help you in your decision making. Avoid. This seems intuitive, but as I see this all the time, avoid treating things without diagnosis. This is specifically in particular for things that are invasive, but you could extend that to pharmacologic treatment, I suppose, too. So have that differential diagnosis, take a stab at it. If you're not happy with it or you don't have any idea, then you continue with your kind of diagnostic pursue. So I'll be happy to answer any questions now or later, but I'll now turn the time over to Thank you so much.